I'd like to talk in the next 30 minutes about clinical strategies for cure, and I'd like to start with what is HIV cure, and is it even possible, and what are some of the clinical strategies that we are studying, and finally ending with a short movie of 4 ties that talk about HIV cure. And so I do hope that you'll find this useful for clinicians, for educators. Perhaps it will help you in explaining, sharing about HIV cure with people living with HIV, and for researchers, hopefully in some ways it will help in the research that you're doing. So when we talk about HIV cure, we really mean 2 things. One is a goal that we aspire to, is to have eradication of HIV. So with this, we mean that we would completely get rid of all cells that are capable of producing HIV. This is very, very difficult to do, as Sharon has mentioned. And so in the near-term goal that we have is HIV remission, or trying to help people be able to come off their antiretroviral treatment, but yet still have undetectable plasma viral load. And they would be healthy and would be at no increased risk of transmitting HIV to others compared to people who are on long-term ART. So far there are 2 ways that people can achieve HIV remission. And here you can see a graph of viral load versus time off ART. And the first blue line is a typical patient. If you take someone off ART, you would expect that the viral load would rebound in a matter of weeks, and definitely less than 2 months. But we have seen cases like the Boston patients, or Timothy Brown, the Berlin patient that Sharon showed, that people have had either transient remission, or in the case of Berlin patient, maybe even eradication with bone marrow transplantation. But we, of course, as a field, we don't want this to be the treatment for HIV remission. And we have seen that people who start treatment early can also achieve HIV remission, such as the Mississippi child who was treated within the first day or 2 of life, or people in various adult cohorts that have had HIV remission. But HIV remission is very uncommon, even in people who start ART very early. And many of you have heard of the Visconti cohort. These are adults in France, and they've been reported that 15% of people who start treatment early are able to be in HIV remission for several years. But if you think about this, there are millions and millions of people living with HIV in the world, and we're talking here about just a handful of people. Even the Visconti cohort has only 14 people. There are studies showing 9% of HIV remission or 5% of HIV remission. And again, these are very, very few people in the world. And there are a bunch of studies that don't show anyone who start treatment early that can actually get to remission, including pediatric case reports of children who were treated extremely early. So why is it so difficult? And you've heard already from Sharon about that, but you know, do we have actually biomarkers that we can tell who might go into remission and who might not? And at this point, we don't know what the biomarkers of HIV remission are, but clinical studies have shown that it's probably a complex interplay between having low reservoir and better immunity, and also host factors. We've seen that people with low reservoir size and better immunity tend to have a higher chance of getting to remission. Sorry, something is blocking my view here. Okay. So I'd like to talk a little bit about the strategies that are being studied to try to limit or reduce HIV persistence. And here, one of the most effective way to try to reduce the HIV reservoir size is starting treatment very early. You're preventing the HIV reservoir establishment or reducing it. And even if we don't find people early enough and we start ART, it's still important to try to help our patients maintain viral suppression. And there are other strategies that are being studied, which some can either be given at time of ART initiation or after viral suppression, like latency reversing agents, trying to use immune strategies to get rid of infected cells, or making cells resistant to HIV. So I'd like to show you these data from Thailand. And this is showing the HIV reservoir size in people with acute infection who were either treated or not treated immediately. And here the total HIV DNA versus time after enrollment. And these people are enrolled in the study just a couple of weeks after their onset of infection. The blue line shows a cohort of acutes that were not treated, and the red line are the ones treated that was done at the Thai Red Cross AIDS Research Center. And you can see here that if treatment is not instituted right away, the HIV reservoir size shoots up immediately. By 2 weeks, it hits the peak, and then it comes down very little, and then sets the stage of what the reservoir size would be in chronic infection. So with early treatment, very early on, within 2 to 4 weeks, we see a 20-fold difference in reservoir size, and by 3 years, the difference is 300-fold. Another way to look at markers of HIV reservoir size is seronegativity. And here we looked at people who were started on treatment very early at the Thai Red Cross. And if we just look at this bar, this is people who were treated in PHEBIC-1, so about 2 to 3 weeks following the onset of infection. And you think about this, this is week 24 data. So these people have had HIV for more than 6 months, but 61% are still negative by the most sensitive HIV testing method we have, the 4th generation antigen-antibody combo assay. This is important in several ways. For our own patients, it's important that they understand that this does not mean that they have been cured for HIV. It's a matter of getting treatment very early. The other thing is, for our patients, it's really a good thing to test negative to HIV, because in Thailand, you still require HIV testing to get a job, and it's just difficult being HIV positive. So this is something that I think we may actually see more commonly as people get treatment earlier. So I'd like to just have one slide about children. I'm a pediatrician, and this is something I'm very passionate about. And pediatrics is a really good opportunity to try to institute treatment very early, because children actually have a very favorable immune development composition. This is looking just about the CD4 T cells, comparing to children who started treatment early versus adults who start treatment early. And you can see here that children have more naive CD4 T cells and less central memory CD4 T cells. This is important because naive CD4 T cells are relatively resistant to HIV, and central memory CD4 T cells are the prime targets for latency. So in fact, when we measure the HIV reservoir size in children who started treatment early, we see that they really have quite a low reservoir size and lower than the adults that are in HIV remission in the Visconti cohort. So I'd like to now talk about the different clinical studies that have been done in adults. And all of these studies so far have been done in adults who started treatment in chronic HIV infection. So they already start off with a larger reservoir size than the people I've talked to you about just now. And this is a study done by Sharon and her colleagues using disulfiram. And you may know this is an old drug that has been used for alcohol dependency for over 50, 60 years. So it's quite safe, and it's been shown to be able to reactivate latency. So here they gave, I don't know what happened in my slides, but so here they gave disulfiram 3 doses and measure cell-associated RNA. So when we're trying to reactivate the latency, what we want to see is increase in RNA in the cell or in the blood. And you can see clearly that there's a spike when disulfiram was given, and even 30 days afterwards, there's still an increase in cell-associated RNA. And when they looked at the plasma viral load, we also see an increase in plasma viral load. So this shows that disulfiram actually reactivates the latent reservoir, and because it's safe, it may be able to be used in combination with other agents. Another drug that is one of the most potent latency reversing agent is TLR7 agonist. And this is a drug that in this study has been used in monkeys that were infected with simian immunodeficiency virus. So you can see here when they measure the reservoir size in memory CD4 T cells, before and after TLR7 agonist, they see that actually it decreases the reservoir size, not only in blood and in tissue. And you've heard from Sharon that most of the LRAs actually have not shown this. And when they stopped treatment in the monkeys, the ART in the monkeys, they show that 1 in 3 monkeys actually went into viral remission, and none of the controls did. So this is very early studies, and this drug is being used now, studied now for hepatitis B, and human studies for HIV are underway. Now, how about using latency reversing agent in combination with a kill? And this is a study presented earlier this year at CROI. So this study, they first vaccinate with a vaccine against P24, and then gave a latency reversing agent, Romidepsin, and then stopped ART. So here you can see that when Romidepsin was given, there was increase in plasma viral load in half of the patients. So it does reactivate HIV, latent HIV. So when treatment was interrupted, did it prolong time to viral load rebound? So here's the viral load graph. So it did not, and everyone rebounded in about 14 days, which is the typical time we would expect people to rebound. So this study shows that there was a favorable signal. Romidepsin reactivate latency, reduced the reservoir size, but the vaccine itself did not elicit, I think, a strong enough HIV-specific immune response, and it did not result in delayed of time to viral load rebound. But with this positive signal, I think there's room for optimization and improvement for further studies. So another vaccine that is quite promising is a CMV-based vaccine that showed to be able to eradicate virus in half of the monkeys. So what they did in this study is vaccinate the monkeys before the monkeys were infected with SIV. So the vaccine actually did not prevent any monkeys from infection, but what it did here, you can see the top lines are the typical progression in monkeys, but the bottom line, 8 out of 9 monkeys actually went on, and SIV was completely eradicated from all cells and all tissue. And what is also remarkable, some of the monkeys were later on reinfected with SIV, and they again cleared the infection. So this is likely because CMV vaccine is a replicating vector, so there's ongoing immune surveillance, and some monkeys had very early immune responses that was helpful. And so a highly attenuated version of this vaccine is being developed and will be tested in humans. So another way to try to kill infected cell is using antibody. And the idea of this is that you have a cell with HIV envelope on the surface. The antibody can bind that cell, clear it, or can bind HIV that's floating around and clear that as well. And so a study that used 3BNC117 antibody in people who had high viremia showed that the viral load change is shown here. The viral load dropped when the antibody was given. After the antibody cleared from the blood, the viral load went up again. So it's clear that antibody can suppress plasma viral load, but whether it can clear latently infected cell is still not well understood, because a cell that is latently infected by definition does not have any HIV on the surface. So then where would the antibody bind? So that's a subject of investigation. Now, there was another study presented at CROI this year using VRC01, broadly neutralizing antibody in people who have chronic infection that are viral load suppressed on ART. And what they did, they gave VRC01 1 week before treatment interruption, and then every 3 weeks. So you can see clearly here that everyone rebounded. The VRC01 did not prevent viral load rebound. The time to viral load rebound was just slightly longer, but not really very significant. But why is this not helping? I think because in chronic HIV infection, people have mutations. They already have virus that are resistant to the antibody. So this then becomes the future research question, whether if we actually give antibody to people who were treated in acute infection before resistance developed, would that help? And also, if we give it in chronic infection, we will need 2 or 3 antibodies to cover the resistance, and there are ways to test for resistance prior to giving the antibody as well. So another way is to make cells resistant to HIV. And how they did this was doing leukapheresis. You take billions of cells, use gene therapy to break the CCR5 genes, and then repopulate these resistant cells, give them back to the same patient. So what they have found is that people who got the gene editing therapy had reduction in the reservoir size. And in some people, the viral load actually came down after treatment interruption. And these are the people who already had high frequency of the resistant cells because they either lack one of the two CCR5 genes. So current studies are looking at using gene editing therapy in people who are already heterozygotes to CCR5 or giving low-dose chemotherapy to increase engraftment of these cells. So you've already seen that therapies, single therapies, it's very difficult to get to HIV remission, and we pretty much in the field agree that we would need combination therapy. So each trial, even with 10 patients, could take 1 to 2 years to even start. And so how do we actually get to where we want to be? And I think this is one possible roadmap, is trying to use animal studies to help us sort out what combinations might be useful. And we could start with animal safety study, and what combinations that are safe could go to animal efficacy study as well as human safety study. And then the combinations that survive these would be going into phase 2 human studies. And I think even in this very, very early stage of cure research, parallel behavioral ethics, social research is very important, because all these studies are high risk, and there's more risk than benefit, and there's actually probably no benefit personally to the volunteers themselves. And so we really have to understand how we can do this well. Now, if we had HIV remission treatment, what might it look like? I think no one really knows, and this is just a guess. We likely would be using HIV remission treatment in people who are already viral load suppressed. We likely would not have such a powerful treatment that you would give one time and people would go into remission. So we might have some modestly effective drugs that are safe enough, and we could dose them more frequently, such as latency reversing agents, and then come in with repeated doses of immunotherapeutics to try to kill the infected cell. And then when people reach a set of biomarkers, and we have many studies now in the field trying to look for biomarkers for remission, if people hit that, then they could have treatment interruption but be followed very carefully, and then some people might have remission, some people might rebound right away, some people might rebound later, and then they would resume treatment. So would such a treatment ever be cost effective? And this is a study that Sharon did with her colleagues looking at mathematical modeling using data from Zimbabwe. What will happen in the next 20 years, comparing using ART daily and monitoring to an assumption that HIV remission treatment would be done in people who've been on treatment, ART, for at least 6 months, viral load suppressed. The HIV remission treatment would be just 6 months, and then the majority would actually have a successful outcome. Even with this very high bar of HIV remission treatment goals, it would be cost effective for the general HIV population if it's $1,400 or less. This is not something we have right now or may have in the very, very near future. But I think that if it is successful, the study has shown that it could save hundreds and millions of dollars. And particularly if the viral load monitoring could be cheaper, it would be more cost effective. And you might remember many, many years ago, people say it would have never been possible to treat millions of people with ART around the world. And I think this is a case that we can work towards a goal of HIV remission that is cost effective in the future. So I'd like to share with you a little bit about what we're doing in Bangkok in terms of HIV Cure trials and what our volunteers think about these trials. So we have the RV254 cohort that we've seen low reservoir size. We're now conducting a variety of analytical treatment interruption studies, either with very early treatment alone, with antibody, vaccine. with combination therapy, and we monitor people every 3 days for viral load rebound, looking for time to viral load rebound and predictors for prolonged time to viral load rebound. So we ask our potential volunteers, so these are all the acutely treated participants who will be volunteers or will be asked to volunteer in these studies. We call these studies viral suppression trial, and this is what we told them, that you may be asked to start using experimental drugs, you may be asked to stop treatment. We don't know, we don't have much experience, we don't know if it's safe, we don't know it will work. We know that this will likely not improve your health. So then we asked them, would you think that you would have a definite or big chance or no or small chance to have benefit or risk? So even reading that, 65% thought that they would have personal benefits of coming into these trials, and 71% thought they would have scientific benefits, and only 4% said that they would think that they would have definite harm. And we also asked them, would you likely or somewhat likely to participate, or would you not likely to participate? And almost 60% said they would be likely to participate in a trial that has treatment interruption, and even more said to take experimental drugs. And what is interesting is how people answered on the right had nothing to do with how they answered on the left. But nevertheless, as a researcher and as a group at the Thai Red Cross, we, and in the US as well, we take this very seriously because this is expectation that we cannot meet. In the initial trials, we know that most people, or almost all, will rebound. What we're trying to do is to try to find what might be the marker for people who might rebound later. And then we're stretching the time from viral load rebound from 1 month to 3 months to 6 months, hoping to design better trials in the future. And that's why we have behavioral social science alongside all these studies that we will be doing. So we are on the journey towards HIV remission. I think starting treatment as early as possible will help limit the HIV reservoir size. Trying to find ART that could penetrate the tissue better will help. Combination remission therapy to try to reduce the latent reservoir. And we need immune therapy that could have persistent immune surveillance to try to kill infected cells that become reactivate. And then with this, I believe that in the future, we can reach long-term remission. So I'd like to acknowledge our volunteers on all our studies that have given us so much, and all the researchers, Professor Lewin, who gave comments on the slides, and many people who gave slides, and as well as our funders.